Greetings, my name is Anna Chengalwala and I'm a computer science major. I'll be presenting my research on unlocking the dynamic connection between education level and COVID-19 vaccination uptake in the US. The scars of COVID-19 pandemic still remain fresh in the minds of many. The pandemic affected different sectors such as health, education, tourism, and manufacturing industries. Others also lost their lives to the virus, which spread faster daily at an alarming rate. According to research, widespread vaccination is indispensable to ending the pandemic spread of COVID-19. My research investigates the link between COVID-19 vaccination intake and education level. I was motivated to determine whether education levels contributed to vaccine hesitancy. Why should you be concerned? The COVID-19 pandemic is a public health issue that affects everyone. My research is consistent with the previous research that was done to investigate education level and COVID-19 vaccination willingness in adolescents, and it was discovered that willingness to receive COVID-19 vaccination was higher in students compared to apprentices who are considered to have a lower education level than students. The research question that guided my study was, does the level of education outcome have an effect on the decision to take the COVID-19 vaccination? Some of the associations that I tested was, is education outcome associated with taking the COVID-19 vaccination? Does the level of education outcome and decision to take the COVID-19 vaccination differ in males and females? I used R and R Studio for my analysis. The sample for the study, which had a size of 116,274 respondents, was taken from the IPIMS Health Survey. IPIMS is part of the Institute of Social Research and Data Innovation at the University of Minnesota. IPIMS Health Surveys offer free individual-level survey data for research purposes from the National Health Interview Survey (NHIS) and the Medical Expenditure Panel Survey. The population of interest for the IPIMS Health Survey is USA citizens, and it primarily uses surveys to collect data. The data was collected on February 1st, 2022. The education outcome data was retrieved from a variable encoded as EDUC in the survey. Individuals were asked about the highest level of schooling they have had, so they were given a card with different categories and asked to choose the category that best fit their descriptions. Individuals who are still in school were assumed to have completed their previous grade. The format of the variable EDUC was in numeric form. I therefore had to collapse the variable into three different categories. Since it's a categorical variable, I had K-12, which is the lowest level of education in the US, secondary, and tertiary, which is the highest level of education. The response variable was encoded as CVD test in the survey. Sample children and adults were questioned. Respondents were asked whether they had been tested for coronavirus. 1 indicated a no and 2 indicated a yes. Since the responses were numerical, I also collapsed them into a no and a yes. Responses such as unknown refused, unknown not ascertained, unknown don't know were marked as NAs as they were irrelevant to the study. I also proceeded to carry out a univariate analysis to understand the distribution of each of the variables in the sample. I also did a bivariate analysis between education outcome and COVID vaccination, education outcome and gender to find out whether there was an association between these variables. Additionally, I carried out a moderation analysis to understand whether education level and COVID vaccination differ in males and females. I consider the type of associations of the variables under research to guide the decision on which statistical method to employ. My associations were C2C, hence my use of the chi-square test statistic. I implemented hypothesis testing to develop a null and an alternative hypothesis. The chi-square is used to determine if two categorical variables are independent or related. I made an assumption that the sample is random, as the codebook did not explicitly state that the sample was random. As for the other conditions, which include having a larger sample and expected counts greater than 5, no assumptions were made as they were all met. After conducting the chi-square test, I obtained the following results. The significance level for this research is 0.05. The p-value obtained is less than the significance level, which indicates that the evidence provided is strong enough to reject the null hypothesis, suggesting that education outcome and COVID vaccination are dependent variables. Since the results rejected the null hypothesis and accept that there exists a relationship between education outcome and COVID vaccination, I conducted a post-hoc test to better understand which categories were causing the difference. From the post-hoc comparisons, individuals who had achieved tertiary education reported significantly more COVID vaccination intake compared to those with K-12 and secondary education. All other comparisons were statistically similar. The results from the moderation test suggest that there is a significant effects between the variables COVID vaccination and education outcome on the variable sex, which is gender, the gender variable. The output is split by gender so that we can see how the interaction effect differs by gender. For females, we see more cases of COVID-19 vaccination intake among those with lower levels of education and higher levels of education than males. However, the distinction is not quite clear for males, as is the case for females, and the proportion of males across all education categories appears almost equal. The analysis of the results show that people with lower levels of education are more hesitant to go for COVID-19 vaccination compared to people with higher levels of education. The evidence from the results show that people's decisions to take COVID-19 vaccination is significantly influenced by the level of education. According to research, possible explanation can be attributed to pre-existing vaccine hesitancy in these groups, lower awareness and health literacy, lower trust and interaction with healthcare professionals, and cost-based concerns. This discovery will help policymakers strategize how to bring on board groups with lower levels of education to increase COVID-19 vaccination intake. A limitation with my research is that the data collected from the surveys was self-reported by the respondents, which could have been subject to recall bias, inaccuracies due to respondents' subjective interpretation, or the research questions may have been framed to influence the respondents' responses. Further research can be done to cater for lacking variables like other socioeconomic factors such as access to healthcare, geographical location, individual beliefs and attitudes, which may have influenced people's decisions to take COVID-19 vaccination or not. These are the sources I used for my research. I do hope my research contributes to more enlightenment about the link between COVID vaccination and education outcome, and I hope it has raised the need to do further investigation on the topic. Thank you.